Last but not least, in Chapter 38, parathyroid hormones. Parathyroid hormones maintain calcium homeostasis. So calcium is essential for muscle contraction, and it's needed by all tissues to cause that muscle contraction. Plasma calcium levels are strictly regulated by three hormones: calcitonin, parathyroid hormone, and calcitriol. Let's deal with calcitriol first. It's a form of vitamin D that simply helps the calcium get absorbed into the blood stream from the GI tract. So that's an easy one. If we don't have calcitriol, we're going to have less absorption. Parathyroid hormone and calcitonin were completely opposite of each other. Elevated plasma calcium leads to calcitonin secretion, which basically pulls calcium from the bloodstream into bones, whereas elevated or low calcium levels, hypocalcemia, stimulate secretion of PTH, which releases calcium from bones. I'm not going to go too deeply into under calcium homeostasis where they talk about osteoblasts and osteoclasts. Just try to remember that PTH pulls or releases calcium from bones and calcitonin pulls calcium into bones. PTH increases blood calcium levels and calcitonin decreases blood calcium levels. Keep that in mind as we kind of move forward, because calcitonin is going to be a treatment for not only hypercalcemia, but also for osteoporosis, so we can pull more calcium into bones and make them stronger. So let's move on to treating calcium disorders. So hypocalcemia can result from vitamin D deficiency, thyroid tumors, chronic renal dialysis, diarrhea, and pregnancy. It generally causes too little calcium in the blood causes hyperexcitability of the neuromuscular system, which leads to spastic muscle contractions, convulsions, and paresthesia, or a prickling, tingling, creeping sensation. Tetany is the inability of the muscles to relax, and that occurs when the plasma calcium level falls to below 6 milligrams per deciliter. It's treated by rapid administration of intravenous calcium and then followed by oral calcium and vitamin D. And remember, vitamin D, similar to calcitriol, allows calcium to get absorbed from the GI tract. So hypoparathyroidism is not usually treated by replacement of the missing hormone. Instead, it's treated by replacing calcium and vitamin D because it makes it immediately available for use. There is parathyroid hormone called teriparatide, which is called Forteo, that is used for the management of osteoporosis. Hypocalcemia is usually managed by calcium salts and vitamin D derivatives. Administration, we talked about that. Okay, so calcium salts and vitamin D preparations are not harmless medications. They can lead to hypercalcemia and kidney stone formation, which can be dangerous to our patients. Hypercalcemia, which is the next section, opposite of our hypocalcemia, can result from tumors in the parathyroid gland, but this isn't the most frequent cause. Usually it's certain malignancies, multiple myeloma, or renal dysfunction. Over time, hypercalcemia can lead to calcium deposits throughout the body, which can cause irreversible damage to whichever tissues it's been deposited in, specifically the cornea and the kidneys. Management of chronic hypercalcemia includes diuretics, because when we get rid of water, oftentimes our other electrolytes will follow. Bisphosphonates and calcitonin, which pull the calcium out of the bloodstream and into the bones. So let's talk a little bit about osteoporosis and Paget's disease. In Paget's disease, bone metabolism is hyperactive in some but not all bones, meaning the bone is constantly turning over. New bone is being made and old bone is being broken down. So if we are hyperactive in our bone metabolism, it means that the newly laid bone is soft and calcified but still fragile. So it can cause, left untreated, it can cause microfractures as well as bone pain, which can be pretty severe. Osteoporosis is a condition that affects elderly people, and it results from increased bone resorption that doesn't balance out with bone creation after a certain age. So usually it's affected, usually women are affected more often than men because we lose, our estrogen sort of depletes as we get older and we hit menopause. So factors that can precipitate osteoporosis include premature menopause, being lean and of short stature, being Caucasian or Oriental, treatment with corticosteroids or phenytoin, smoking, alcoholism, and family history of osteoporosis. So calcium absorption decreases as estrogen activity decreases, so that's why women who are older and are in menopause who no longer have as much estrogen in their body are more likely to develop osteoporosis. So the goal here is to prevent bone fractures, and our objective is to increase bone mineral density, increase the strength of our bones by getting calcium back into the bones. Our first therapy that we're going to talk about is calcitonin, and that is a synthetic polypeptide hormone that is administered to patients. And we talked earlier about calcitonin pulls calcium from the bloodstream back into the bones. Calcitonin is available nasally or as an injection, so there's a couple different options there for patients. It's pretty common to have allergic reactions, so sometimes this medication can't always be used, and drug resistance can develop as well. So just keep that in mind for that medication. Usual side effects of the IV administration are nausea, vomiting, diarrhea, and injection site reactions. Nasal preparations are associated with rhinitis, insomnia, anxiety, and headache. Next medication that we're going to be moving on to, and the last one, I believe, except for estrogen, which is more of a replacement than a treatment, is bisphosphonates. And this is sort of the hallmark drug for treatment of osteoporosis. And what it does is it inhibits the normal and abnormal bone resorption, and it basically slows the bone breakdown down. So it allows even though, the bone breakdown after a certain age is more than the bone buildup, this slows it down so it balances out more and it looks more normal. Drugs you might hear of in this class are alendronate, pamidronate, risedronate, and zoledronic acid. Most of them are available PO, however, zoledronic acid is an infusion. These drugs are generally given first thing in the morning, just like our thyroid hormones, once a week on an empty stomach, and the patient has to remain upright so that the medication has time to make it down to the stomach and get absorbed. They're not taken with food, and they're given with a full glass of water. They're also given with, not at the same time, but we make sure that these patients are also taking calcium and vitamin D. That way there's enough calcium in the blood to get absorbed back into the bone. There's a number of drug and food interactions. Again, we kind of just talked about the reason we separated out is to prevent those because the GI absorption is pretty poor. So we want to make sure that the only thing in the stomach at that point in time is water and our medication. It can cause GI irritation, so you might want to be aware of that in patients who have a history of GI ulcers. It also causes flatulence, headache, dry mouth, and musculoskeletal pain. So, estrogen, again, we talked about that. It's just a replacement therapy in this case. If we replenish estrogen, we're allowing calcium to get absorbed back into the bones. So it's sort of a hand-in-hand thing. There's a medication called raloxifene, and that is what is called a selective estrogen receptor modulator. It's estrogen, but it is selective for bone when it's doing its estrogenic actions. If we give estrogen to an elderly patient or an older woman, we are putting them at risk for breast cancer as well as uterine cancer. So this selective estrogen receptor modulator allows us to focus just on the bone and not have that risk of breast and uterine cancer. So that finishes up Chapter 38. Chapter 39 will probably be posted by tomorrow afternoon. Please contact me with any questions. I think I say that at the end of every chapter, but you guys should know that by now. Email me if you ever need anything, and I look forward to seeing you all next week.